Let's start reviewing some of the different hearing testing modalities that we have for very young children in particular. This is different than older patients or children who can follow instructions. And for example, if you put them in a hearing booth, ask them whether they hear a tone or not in one ear. That's a fairly straightforward and easy test to perform. However, you can imagine if you have an infant or a very young child who may not yet be cooperative, it's difficult to measure those hearing tests behaviorally. That's still possible, and in general, once children reach approximately 7 or 8 months of age, it's frequently possible to obtain a behavioral hearing test through conditioned response or visual reinforcement audiometry. And we've looked at some of those audiograms before. In contrast, let's look in the newborn period. And this is critical because one of the key elements is to identify any type of hearing impairment or hearing loss as early as possible so that early interventions can be acquired and put in place. Probably the gold standard for doing hearing testing in very young children or difficult to test children is something called an ABR, or auditory brainstem response test. In this testing method, what the audiologist will do is place 2 sticky electrodes, one on the forehead and one behind the ear being tested, and then place a small ear insert in that delivers the sound to that ear. We know that from physiologic testing and very early laboratory studies that if you deliver a sound to the ear, it should trigger an electrical chain of impulses that go through the hearing centers of your brain. Those sticky electrodes that you place on the forehead and behind the ear can detect those electrical impulses, and based upon that electrical response, you can determine the level of hearing for the child. The key thing is this one is obviously a passive test, and the child doesn't have to respond at all in order for the audiologist to be able to measure the hearing responses. Earlier, one of the challenges was that if the child was awake and crying or very active, then the brain's electrical activity from all of those would cause an artifact, and sometimes it was difficult to obtain the ABR measure that the audiologist was seeking. As a result, a lot of the ABR studies were initially done with a child either under natural sleep, which is very possible when the child's very young, or they would have to be put under sedation so that they weren't moving and fidgeting around and distorting the ABR test. These days, one of the most helpful emerging technologies is that computer scientists have been able to eliminate the background noise generated by a child's activity. And so now it's feasible to do an awake ABR, but that technology may not be universally available for everyone just yet. If you can avoid sedations, which is a very common condition and scenario that we try to do in our people with charge syndrome who've had multiple anesthetic exposures, something like an unsedated or natural sleep ABR is much more attractive and practical. So the ABR gives us an accurate measure of a child's ear. It can also test it ear specifically, so you can test the right ear first and then the left ear and get very precise information that then helps the audiologist determine the level of hearing loss, as well as what's the proper hearing aid or support for hearing that needs to be put in place. Another common hearing test is shown on the next slide, and this is an otoacoustic emissions test. The important thing about this is that, again, it's a passive test in which the child doesn't need to respond, and it gives us some reflection of the measure of how the cochlea hair cells are working. So to step backwards just a little bit, inside the cochlea, which is the true hearing organ inside the inner ear, there are approximately 14 to 15,000 hair cells. These hair cells are the ones that actually detect sound waves as they come into the ear and transform those sound waves into an electrical impulse that's then conducted down the hearing nerve to the brain. In the vast majority of people who have what we call a sensory neural hearing loss, those hair cells are either non-functional or they're just missing. So this otoacoustic emissions test measures the functioning of those hair cells, which is obviously important. By sending in a small sound down the ear canal, the hair cells are triggered and you get a mechanical and auditory response. So a sound is almost reflexively sent back out the ear canal that's very minute from the movement of those hair cells. In general, what we're looking for is a positive or negative response. So seeing whether those hair cells actually generate this reflexive response. But notable, the otoacoustic emissions test does not actually measure a child's hearing level. That's very different than the ABR hearing test or the behavioral hearing test that you do in a booth. The sole thing that the otoacoustic emissions test shows you is whether or not those hair cells are functioning. The value of this is that it helps the audiologist as well as the clinicians determine where the site of lesion or where the problem is along the hearing pathway. In concert with the ABR, and otoacoustic emissions test really gives the audiologist a more complete picture of what the child's auditory system is like and what parts are functioning well or not. So in summary, if you are trying to figure out somebody's auditory system and their hearing, there's a variety of tests that the audiologist will perform. The routine behavioral audiogram is still one of the best tests, and behaviorally, it reflects day-to-day life quite accurately. The challenge is that younger and younger individuals are more difficult to test, and that's when we'll start pulling in certain testing such as an ABR as well as an otoacoustic emissions test. That battery of tests frequently is performed together, especially in complex individuals who have perhaps ear anomalies or other conditions that might affect hearing, speech, and language.